understand treatment options. And then we're going to have a little section on preparing for the visits and so on, and second opinions, clinical trials that are available. And then we'll talk a little bit about emotional support and that kind of thing. And then of course there is always a part of caregivers, because families and caregivers are an incredibly important part of this. And in fact, they're the ones who are struggle with this quite a bit as well, not as quite as much as the patient, but obviously usually the caregivers are loved ones, and they care a great deal about the person they're caring for and need support as well. And then, how do you find that support? Some of us have it right within our family or immediate community, but you can find that. There are mechanisms of support like this talk and the community, and this cancer support community that we have in St. Louis. So without further ado, I'm going to go ahead and get going. So a gynecologic oncologist is a person who cares for GYN cancers. And if you have a GYN cancer, there's a myriad of data that shows that GYN oncologists actually, who are experts in this area, there's a survival advantage to being cared for by a GYN oncologist if you have a gynecologic cancer. Sort of the not so new kid on the block, but something that has just become available probably routinely in the last 20 years, and more significantly in the last 5 to 10 years, and is increasing in availability and power, if you will, almost daily. Of course, there are biomarker testing, CA-125, for instance, for ovary. There are a variety of other markers, but CA-125 for ovary is probably the most prevalent. So what are gynecologic cancers? Any type of cancer that starts in the female reproductive organs of someone that's assigned a female gender at birth. The one that we hear about the most is probably ovarian cancer, because it has the highest mortality. And if you will, we've had a great deal of success with treatment. Fallopian tube cancers, though somewhat less, are really the same as ovarian cancer. And there is a theory that actually the ovarian cancers begin, certainly the serous type cancers, which is the garden variety ovarian cancer, begins in the fallopian tube. And then actually those cells are exfoliated and light on the ovary. And we interpret this for many, many years as ovarian cancer, but probably these tumors arise in the fallopian tube. Now, there is a uterine cancer. Endometrial cancer actually is the most common type of cancer, and its incidence is increasing significantly. Over the last 2 decades, it's increased from 45,000 cases a year to this year, there's going to be probably 63,000 cases. And for the first time, endometrial cancer death will exceed ovarian cancer, not the death rate, but the overall incidence. Cervical cancer, of course, is the one cancer that we've had a huge amount of success with. Worldwide, cervical cancer is the second, sometimes the third greatest killer of women. But that's in under-resourced countries. In the United States, there'll be about 11,000 cases a year, maybe now down to 9, thanks to pap smear screening and HPV testing. And we hope that number will continue to fall with the advent of the HPV vaccine, which many of you might have heard about. Vaginal cancer is exceedingly rare. Vulvar cancer is a little more common. Nowadays, of course, that's usually is manifested by a small lesion on the vulva. Most women in our society actually seek help early, as opposed to perhaps in your mother's or my mother's generation, where these cancers sadly presented late because societal norms prevented women from seeking care early in this setting or even examining themselves. So what about risk factors? Well, risk factors, age is always a risk factor for cancer. I mean, the older that you get, the more likely you are able to accumulate abnormalities in your DNA, and that can lead to uncontrolled growth. So the good, societies in which the average lifespan of women is young, like sub-Saharan Africa and so on, where many women die during childbirth and so on, cervical cancer is quite common, but ovary and endometrial that occur in postmenopausal women is quite rare. Ethnicity is a feature. For instance, women of Jewish heritage are more commonly going to have a BRCA mutation, so they'll have hereditary ovarian cancer. Patients who are African American will more likely have serous cancer of the endometrium, the mortality of which can be as high as 50% in that particular. Endometriosis may or may not increase your risk of some sort of malignancy. Certainly, late childbearing is associated with ovarian cancer, not endometrial cancer. Family history of ovarian cancer, of course, is high. A family history of ovarian cancer is associated with uterine cancer, endometrial cancer. Uterine cancer is associated with colon cancer through the Lynch syndrome, or HNPCC, hereditary non-polyposis colon cancer mechanism. That's called the mismatch repair abnormality. So let's just kick off with ovary, since as we talked about, it begins in the ovaries, or it's identified as beginning in the ovaries, but as I sort of alluded to, it's really probably the garden variety. The serous type may in fact arise within the distal fallopian tube. And as stated here, ovarian cancer is a broad term, usually includes ovarian, fallopian tube, and peritoneal cancers. What happened? So what is cancer staging? Well, staging is just the extent of the disease. And why is it necessary? Because it will determine treatment. It'll determine where the disease is. If the disease is confined to the organ of origin, cervix, endometrium, or maybe even ovary, then no further therapy may be necessary. Whereas obviously, if there's metastatic disease that is spread outside of the organ of origin, then treatment is likely necessary. Imaging might include a CT scan, might include a PET scan. More commonly with cervix, almost always a PET scan is performed, but with the other diseases, endometrium and ovary, a PET scan is less useful. Blood work, may be helpful. That is to, CA-125 is a marker for ovarian cancer, and the higher the elevation, the more likely it represents it's just proportional to the volume of disease present. Obviously, as your stage clearly impacts treatment, because if it's widely spread, then chemotherapy would be an option. If it's just local, then radiation might be an option. But obviously, treatment will depend on where the disease has metastasized to or spread to. Fallopian tube cancer, we used to think of it's rare, but now, as I just alluded to, it's linked with many with ovarian cancer. And it's treated the exact same way. So there's no difference between what we would call fallopian tube and ovarian cancer in terms of treatment options and so on. Cervical cancer, of course, is the disease, as you can see. It's a cancer of the mouth to the womb. Historically, that was the most common gynecologic malignancies, but thankfully, because of the pap smear, that has diminished, and we hope it will diminish further with the vaccine to against HPV, human papillomavirus, which is responsible for 99.9% of cervical cancers. It says that it's slow growing here. And that's not, I wouldn't say it's slow growing as much as because the cervix is exposed, we can examine the cervix and get a pap smear. We can diagnose it early, and in fact, often in the pre-malignant phase. As I spoke about earlier, the human papillomavirus is almost certainly the causative agent. It may be linked to other cancers, but typically not thought to be. Endometrial cancer or uterine cancer is the cancer of the lining of the uterus, endometrium. So that's the lining of the uterus seen here where the arrow is pointing to the endometrial cavity. It forms in tissues that line the inside of the uterus. And endometrial cancer is by far and away the most common type of a cancer of the uterus. Vaginal cancers are exceedingly rare. Most of the time they represent really a cervical cancer or a vulvar cancer. Again, most of these lower genital tract diseases, that is cervix, vaginal, and vulvar cancer, are caused by human papillomavirus. Although vulvar cancer is usually divided into two types. Older women tend to get non-HPV related, that is non-human papillomaviral related cancer, and younger women tend to be that their cancers tend to be associated with the HPV. There are two types of cancer. Squamous cell is the most common. There can be an adenocarcinoma of the vagina. Usually adenocarcinoma of the cervix is of the endocervix, that is the inside of the cervix, not the outside. And that can often presents as a bigger lesion. It's harder to detect, but adenocarcinoma of the vagina is most commonly associated with DES exposure in utero, and that is actually going away because now we don't use DES. Vulvar cancer is a cancer that's almost always squamous cell cancer, and that's of the external genitalia. So that will be the labia majora or the labia minora. If it and that is usually surgically managed. There can be a rare form of adenocarcinoma of the vulva, but that's usually associated with a Bartholin's gland. So that's a deep gland that's posterior and just a little lateral. That is the back of this. I wish I had a little pointer. Do I have a pointer? Yeah, here. Can you see my pointer? So the Bartholin's gland would be here and here, and that would be where an adenocarcinoma would arise. Now, Paget's disease is a whole different kettle of fish. Paget's disease is a pre-malignant abnormality of the vulva, or it can be of the breast, it can be of the anus, it can be of the colon, but it is associated with other cancers. Most of the time it is pre-malignant, and we excise it and then follow it. Now, having said that, about 20% of the time, or as high as 20% of the time, there can be an invasive or malignant component. And then very, very rarely, there are sarcomas. A basal cell carcinoma is the same kind of cancer that you would get in your skin, and that, related to sun exposure. And that actually is a good kind of cancer to have, if there can be such a thing, because it only requires wide local excision, just like it would on your face or back or scalp. So what signs and symptoms of ovarian cancer certainly are, or metastatic endometrial, would be fatigue, bloating, feeling full. You might get, abdominal pain. You might have a mass that's pushing on your bladder, and so you have frequent urination. It can affect the bowels, and so, or you might have vaginal bleeding. That would be the most common symptom for endometrial cancer or uterine cancer. And of course, you might have pain as well, or bleeding after sex, excuse me, that would be most associated with a cervical cancer. And obviously the symptoms of burning or a lump, that would be most associated with a vulvar cancer. So if, when you go to see a doctor and you're worried about a type of cancer, options are going to be surgery, chemotherapy, targeted therapies, hormonal therapy might be targeted. But now we molecularly test most cancers, and we can often identify a specific molecular or DNA abnormality that's responsible for driving this cancer, and that's called targeted therapy. Radiation therapy is common, but only for localized disease. We do have immunotherapy now. We have like the checkpoint inhibitors. You may have heard of them: pembrolizumab, nivolumab, or Keytruda, which is what you might have seen on a TV ad. And what they do is these particular, the ones that I mentioned, cover up a molecule, a PD-L1 receptor that is thought of as self, and that makes the body think then that it's not self, the cancer is not self, and it will attack then that cancer. And of course, clinical trials are always important because they help us move treatment forward and test new treatments. So if the standard of care, we believe, is if there is a clinical trial available for your disease, that you should take it, that will offer you one of the best options. But you have to choose, of course, the right clinical trial. Are they right for you? And do they fit your particular situation and your cancer? And so that would be something that you'd want to talk with your doctor about. But we do believe, as I said, that there's standard of care. There are certain eligibility requirements. That is, you have to have certain features that will make you eligible for that trial so that we can actually test whether the drug works. So these patients have to have the same kind of cancer, generally around the same number of prior treatments, obviously the similar histologic types, and so on. And then often you might be randomized to treatment arm or no treatment arm, or one kind of treatment versus another. And it's important for you to understand the trial that you might be eligible for and might be undergoing, because it's important for you, I think, you to understand the potential pitfalls or risks, or the possibility that you might not respond to that experimental treatment. So obviously, when you want to have your questions when you go to talk to your doctor, you want to we want to control the disease. I mean, that's the most important thing. How come it's not moving? Oh, I see. You want to probably bring another person for another set of ears. You want to probably take notes, and always ask questions. I think, sometimes people feel afraid to ask questions, but your doctor will want you to ask questions. I don't know. Here's a worksheet. Do you have this sort of worksheet available, Danny, for at the cancer support community?
Yes, we have those worksheets available, and we also have a program where people can come in and we can help people develop their own list of questions to take to their doctor.
So it's really important for you to feel comfortable with what you're doing and ask appropriate questions. I mean, in the end, and the day is done and the race is run. You want to make sure that you are cured. Well, that would be the first goal, but that you have asked all the questions and gotten all the answers to make sure that you're undergoing the best treatment for you, and that you've left no stone unturned. So knock on wood, God forbid that the worst happens, that you know in your mind that you've done the absolute best for yourself or for your family member. So what is the most important thing for you to be able to do? You have to think about that. I mean, is it well-being? Is it how much treatment? Some people will want to be treated until, over and over again, and they're willing to be sick. Some people, I had a 90-year-old patient the other day, just said, no, I don't think I want to be treated anymore. And they may be willing to take one or treatments or none and then stop. I mean, you have to decide what's best for you and where in that spectrum you fit. And then, how much do you want to inform those people around you? How much do you want them to help you? How much do you want them to be involved in your care? And then, do you want to work during treatment or do you not? For instance, some people like to work. They want to work because it takes their mind off of it and they feel sort of an obligate. I mean, a sense of worth, if you will, when they work. And so they will want to work during treatment. Some people do not. I mean, you have to decide what kind of person you are, and your doctor should support you in that. And then, obviously you are here because you want to get some support for either your loved one or yourself. And that's what the cancer support community is for. There are other mechanisms as well. Siteman Cancer Center has cancer psychologists. You may have personal ideas about a counselor or something else. You may want to help other people. For instance, through SLOCA, the St. Louis Ovarian Cancer Awareness Group, we have a group of women who go to the medical students, and at each of the medical schools, SLU and WashU. They also go to many of the resident grand rounds, and there's a panel of 3 or 4 women who talk about their diagnosis and how they were told about their cancer and what they think could have been done better and what they like and don't like about what happened to them, so that the young physicians have a good idea of how to talk to these patients. And then, of course, in terms of quality of life, what's important to you? I mean, what sort of hobbies do you like to do? Now, you may trust your doctor 100%, but it is important. Often, sometimes 2 heads are better than one. Now at WashU, for instance, or Barnes, we have 10 G1 oncologists, and we discuss patients at our tumor conference every week. So in a sense, you're getting 10 opinions. However, many of our patients do go to MD Anderson. We know people there, and like I said, in the end, the responsibility is ours as your physician to make sure that you feel that all stones have been overturned and everything that is possible to do for you has been done. And that is our commitment and job to you as a physician. So second opinions, any doctor who says, well, you shouldn't get a second opinion, is probably not doing their job. I'm just, So what about clinical trials? Well, clinical trials test new treatments for cancer, and that's a good thing, because as you go through the treatment process, particularly in ovary and endometrial, there are multiple steps and multiple first line, second line, third line therapies. The clinical trial offers you an opportunity to increase the number of options open to you, and to also help others in the sense to see if that particular treatment works, or how frequently it works, and where it should be placed in the armamentarium. It usually is a treatment that's not available to you without being actually on the trial. And then, obviously we can find new ways to manage symptoms and side effects. We, advance the understanding of clinical care. That's why clinical trials are important. And you might ask specifically what clinical trials are available for you. And there may not be any, but, and then you always want to ask, what are the potential benefits? Hopefully it's a response. And then obviously, what are the pitfalls of that trial? And then what rights do you have as a participant? Now, all clinical trials have a stop sort of option. That is, if it makes you too sick or you decide at any time that you want to stop, that you just have to say, I want to stop. I don't want to participate anymore. And 100% of the time, the trial in the consent form is written that it's written that you can do that. Your eligibility for a clinical trial will vary on the number of treatments you have, where it is, what histologic type, that is what it looks like under the microscope, and all of those things. So you need to ask if you're eligible for a clinical trial. There may not be a clinical trial specifically for you. You can get information on NIH.gov, clinical trials, NIH.gov. That should have all clinical trials listed and where they can be and where you can be entered on those trials. Some are a long ways away, and you can bring that list into your doctor and have them, talk about some of the better trials that you might be eligible for. Now, you can enroll in the trial if it's at the institution where you're being treated, or your doctor can help you find a place where that trial is open and you could go there. For instance, you can go to the NIH for any NIH trial, and the NIH will pay for your travel, they will pay for your lodging, and they will pay for you to be treated. Now, there aren't that many trials. Then you have like MD Anderson, where you'd have to fly to MD Anderson to be treated once every 3 weeks or so. And then your physician here, for instance, we might help you in the interim time if something happened while you're gone, or it may be standard therapies and we can treat you here. In St. Louis on their trial, if it's not an experimental drug that requires an experimental, what we call IND. Now, sometimes, there are sort of universal challenges associated with cancer. Of course, here you are going along, you're pretty young, you're able to, go swimming on the weekends, you go play golf, or, go to the lake or go camping or whatever you do, cook or bake. And now all of a sudden you have this cancer that makes you feel, and you're getting treated, it makes you feel poorly much of the time. And so there's a significant loss of control. You may actually feel alone. I mean, some of your family members may feel uncomfortable being around you. And obviously you're living with uncertainty. And so all of those things can impact significantly in your life. So important things in the diagnosis are managing the side effects, both of the cancer. Could be pain, could be fullness, could be loss of sexual function, could be depression, many things. And so it's important everybody at WashU anyway, at Siteman, gets a survivor careship plan. Obviously the wellness community or the cancer support community will can help you a great deal. They're outstanding at this effort, and they help you develop a plan. There are a variety of mechanisms for help you with emotional wellness, oncopsychologists, or a counselor. And the cancer support community can put you in touch with someone who could help. Any of your doctors should also be able to do that. But you do kind of have to ask. People say, one of the big side effects that people worry about, of course, or most people, women more than men, since men are often bald anyway, as we age. But hair loss is a big thing. It can change your self-image. And so there are really good wigs nowadays that that one can get, and most of them are paid for through insurance with the right diagnosis. We usually call them hair prostheses, cranial prostheses. But that's often a big thing that patients worry about the most. Doctors do not. We worry about certainly you worry about nausea and vomiting too. But like patients who are getting platinum-based therapy can have neuropathy or numbness in their fingers and toes. Fatigue is a common side effect. You can also have GI symptoms, diarrhea and so on, or swelling in your limbs. Usually that's the result, though, of a surgery and a lymph node dissection. Obviously, in the case of gynecologic cancers, these women are usually postmenopausal already, and when we do a big debulking or remove their uterus, it can cause difficulty, pain with intercourse. And then, just with the surgery and the cancer, loss of hair, just feeling poorly, those patients may feel, less desirable, if you will. You can get with this, particularly with the folate antagonists like methotrexate, or adriamycin, for instance. You can get mouth sores, and we have some magic mouthwash for that. You can lose weight. You may have a colostomy, for instance, that would change your physical appearance and make you self-conscious. I always tell patients to remember that Ed Sullivan, I don't know if many of you are old enough to remember Ed Sullivan, but he got up in front of the crowds for many years with his tuxedo on and a colostomy. So if he can do it, you can do it too. Obviously, if the patient is menopausal, they have their ovaries removed, or premenopausal, they will be put into menopause. And so then they can have attendant hot flashes, and those may need to be managed and that can be associated with, also vaginal dryness and some sexual dysfunction. We do, as some of the long-term side effects and late effects, that is well after treatment, are usually sexually related, or often sexually related. But in terms of vaginal dryness and so on. Certainly a vulvar cancer, you can see could be disfiguring, or there could be some fair amount of scar tissue. With some treatment specific side effects might be cardiotoxicity. That would be unusual in gynecologic cancers because adriamycin would be the primary culprit there. We don't use a lot of adriamycin, though we do use some. We use a lot of Doxil, which is a liposomal bound adriamycin that has markedly less cardiotoxicity. There is something called chemo brain, so there could be cognitive changes. More likely than not, that's related to not to the drug specifically, but probably to the drugs that we use to decrease the symptoms of treatment, decrease nausea and so on. And that prevents laying down a long-term memory. And so that's how that occurs. Neuropathy is a very common thing, especially in those patients who are getting platinum-based therapy. So we see it a lot in our patients who are being treated for ovarian and endometrial cancer. And we can treat that with vitamin B6, followed by gabapentin, and there are some other agents too that are newer on the market that can be beneficial. Now, it's really important while you're undergoing chemotherapy or undergoing treatment to keep active, because sort of use it or lose it is really true. So physical therapy or hiring a personal trainer, making sure you walk every day. If you have a dog, that's a good thing. You can walk your dog. And that will help you, become, maintain your balance and your strength. Many patients obviously are, almost half are concerned about moving around and walking, and you really do have to put forth some significant effort to try to be, quote, normal. The other thing is, eating. Sometimes, when you have cancer and you don't feel like eating, then is not the time necessarily to worry about if you're eating healthy or not, though it's always good. But maybe you do want to kind of put it, need to pack away some extra calories. So in that instance, Ted Drew's might be a good thing, for instance. Obviously, it's important though, likewise, to eat your fruit and vegetables, um, and eat a well-balanced meal if you can. Um, and calcium to protect your bones and to prevent other illnesses. If you're losing weight, as I said, though, it's important to eat healthy, but you can kind of pack in a few, calories that you might not want to pack in when you were healthy. And a movement and exercise is critically important. If you lay around for 6 months or a year while you're getting treatment, that's going to be a bad thing. You're not really going to be able to, it's going to be hard for you to get back to baseline. So it's important to at least stretch. Yoga is a good thing. And balance is of the absolute necessity. What you don't want to do is be inactive or have a little bit of neuropathy and lose your proprioception or your ability to feel yourself in space and fall and break a hip and get put down that way. Also, there's a lot of data that shows that exercise, of course, increases endorphins, which are your sort of endogenous morphines that will make you, quote, feel good. And that's why people feel a rush after running or doing some strenuous exercise. You actually feel pretty good. You are able to sleep well. What are the effects of surgery? Well, obviously we talked about it can change your perception of yourself. If you get a vulvar cancer and you have to have that resected, or if you have to have a colostomy, or just if you have a big scar, if you're losing your hair, all of those things can change your body image, and we should be able to help you and can help you with that. Similarly, sexual intimacy for survivors is, sometimes difficult. A, you might not feel well. B, it might not feel the same. It might be, there might be a fair amount of narrowing of the vagina or dryness, and we can help you with kind of all of those things if but it's important to express those things to your doctor. Fertility is a big issue generally in women who, most women who get cancer, most, not all, do in fact are in fact done with childbearing, but some are not. And so we have to decide then, and you have to talk to your doctor about how important is having a child to you, and how much are you willing to compromise your treatment to retain the ability to have children. Sometimes it's just a matter of asking and just then changing the treatment. But in some situations, it's more than that. So you always have to ask your doctor. For instance, if you're young and you're going to have to undergo some sort of more definitive surgery, you can harvest your eggs before surgery, and they can be stored now for indefinitely. In fact, that's a common thing to have happen for women who feel that they might not get married until late in life. They can harvest their eggs early in their 20s, freeze those eggs, and they will maintain then, because the older the egg, the more difficult it is to be fertilized, and the greater the risk, for instance, of Down syndrome and other genetic abnormalities. So egg storage is a very important and common thing. And it's important then, for you to recognize if you might be getting depressed, or just if you have a lot of questions about your feelings. As I said, we Most places now have oncopsychologists or counselors who can help you. So things that are easily done are join a support group like you're doing now. We have many support groups around the city of the region of St. Louis, including most notably the one that you're participating in now, but there are others. You can work with a therapist, and some people may need that. Obviously, it is okay, and in fact, it's important for you to trust your family. There is a lot of data that shows that those people who have good support systems and feel comfortable with those support systems actually live longer. So that's a very important thing. One thing that we don't like to talk about, and I think all of us as physicians try to minimize this in our cancer patients, is what we call financial toxicity. You're sort of taking care of yourself and your cancer. That's your goal. You shouldn't have to worry about the health insurance too. Sadly, though, in our world, we can't avoid that. But you can minimize it, and you should try to do that. And if you run into trouble, ask for help. There's lots and lots of help available, especially for cancer patients within, believe it or not, the state of Missouri even. There's not help in a lot of things, but cancer there is. And so you just have to ask and get the social worker involved and your doctor as early as possible to minimize that, quote, financial toxicity. Obviously, some of the time we're not entirely successful. The cancer goes away and then it comes back or recurs, or it doesn't go away altogether and then starts getting bigger, and that's called progression. And then, of course, there are other treatments that you have to that you have to consider, and your doctor should offer up those options for you. Again, clinical trials and should be first and foremost, I think, in everyone's mind. Follow-up survivorship. Survivorship didn't used to be such a big deal, right? But it is now. In other words, like in the olden days, if you will, the recurrences were so common and progression was so common that you were pretty much always tied to your doctor. And so survivorship was less important, but now often patients get a complete response and go many, many, many years, decades even, after their cancer. And so the anxiety comes in that sort of safety net, if you will, of going to your doctor every 3 weeks or going every month, and then every 2 months and every 3 months kind of gets spaced out. And so you're kind of alone. And some women, I'm a gynecologic oncologist, so I take care of just women. The survivor, can become anxious because now all of a sudden they're often by themselves without the notion of continued support and examination. And so that can be very anxiety provoking. And so there are ways to deal with that. And you must, of course, plan ahead for those, what I would call good times. That's a good thing to have to plan for how you're going to deal with the worry of not having cancer anymore. And then, of course, there is the anxiety of getting a scan for screening, for continued surveillance, or even coming to the doctor then and waiting for your CA-125 if you have an ovarian cancer. Those are days that are really anxiety provoking for patients. And of course, nowadays there are treatments that we call maintenance therapy. That is, we treat a patient, and I'll give an example of a patient with ovarian cancer. She has no evidence of disease, but after chemotherapy, we're encouraged by that. Do we follow her? That's what we usually do. But what if she has a BRCA1 or a BRCA2 mutation? Well, then we know that we can use an oral drug called a PARP inhibitor. And we can maintain those patients on that maintenance therapy for a year or two, and that will significantly decrease the risk of recurrence. The most common thing that you may have heard about are breast cancer survivors being on hormonal therapy, and being maintained on that. For a while, the limit was 5 years. Now there's data showing that 10 years is helpful, and I'm sure more data will emerge that it could be even longer. So, like post-treatment survivorship care plans, what would those entail? Well, summary of the treatment, obviously how frequently you're going to be followed up, how often you're going to be screened, and you should talk about this with your doctor so that you can sort of anticipate and understand what the long-term plan will be. And if your neuropathy persists, or if your white count doesn't come up, or any number of things, when would you get referred then to a specialist to take care of this? And there can, like if you have sexual dysfunction, sexual sexual counseling may be important. And so that's important. And then there would be the time when the patient has extant cancer, that is present cancer, and they would need palliative care. And that would be, focusing on relief of symptoms and improving your quality of life. And obviously palliative care can and maybe should be given something often during your actual treatment to maximize your quality of life. But you have to tell your doctor what your symptoms are. And then finally, don't forget the person who's taking care of you. That is, your spouse or your significant other, your partner, your kids, your best friend, because they obviously love you and or they wouldn't be caring for you as they are. And so could be stressful on them to do that. And the psychological toll can be great. And so, just be aware of that and help them find support as well. And more we're having groups of people who will actually support the caregivers. And because these people can get burnout, they do need to set limits and pace themselves, and help control their stress. And they have personal needs too that often go unaddressed. And I'll give you an example. I had a patient whose husband had bladder cancer and got a conduit and then had metastatic disease, and she had a vulvar melanoma. And unfortunately, she was so focused on taking care of him that she let her melanoma grow to an untreatable levels, and that actually, obviously was not good for her. So pay attention to yourself if you're a caregiver, and it's okay to take a break, get a babysitter, delegate, and don't overdo it completely. So, and there are caregiver support groups. I'm sure the wellness community can help that. There can be individual counseling as you as a caregiver go through grief for your loved one, and religion can play a big part of that. So I kind of zoomed through this, no pun intended, and I can go back to any number of those slides, but I'm going to ask people to raise their hand and ask for questions from me. I'm happy to do that.
Dr. Much, if you could stop the share of your screen now, and we can maybe look at each other face to face for our question and answer session.
Let me just see. I'll stop. I got it. Okay. How's that?
Great, thank you. And I've also stopped the recording, so people can feel free to put their images back on. Oh, I'm sorry, including myself. I apologize, I took mine off.
There you go.
Okay,
Hi.
here I am.
Okay.
Okay, so yeah, people can feel free to bring their images back up on the screen. And this is a good time for us to be able to ask Dr. Much some questions. Also, while we are asking questions, I'm actually going to copy a link, and I'm going to post it in the chat. That is for our uh, survey. If you could please take a few minutes before you leave the seminar to fill out that survey. That is a survey that's required by our headquarters in order for us to continue to receive funding for these educational workshops. So it's very important that we get those. So if you don't mind taking a few minutes, I would appreciate that. But who has a question that they might want to start out with? Okay, I'm getting one in the chat here from Joyce. I'll go ahead and read that. And feel free to speak out, Joyce, if you're interested. But this question is, what are the 4 components of a survivorship care plan?
Geez, I don't really, it was on the slide, wasn't it? I mean, I don't think.
Yeah,
mean-
but the slide was too fast. I couldn't write that fast.
Oh, I'm sorry. Can we go back?
Yeah. I got the first one, summary of treatment, and then the slide was gone.
Okay, can we go back maybe, and just for.
You know what? Let me see. It might be easier for me to
Just read.
find that.
Yeah, I have that as well.
Oh, do you have it up, Dr. Much?
I do.
Okay.
Let me just see if I can. Yeah, okay. So you want the 4, I'm sorry that I went so fast.
That's okay.
Let me just get back here. So support for taking, I think,
The first one was summary of treatment, and that's all I got, and then the slide was gone.
summary of treatment. Okay. Schedule of follow-up. What screening or additional screening will occur in that follow-up, CAT scans, blood tests and so on. And then finally referrals to specialists, depending on the long-term side effects that one has because of their treatment. Did that help, Joyce?
Yeah, thank you.
So summary of treatment, schedule of follow-up, additional screening, and referrals to specialists. I see that you're a note taker, huh?
Yeah. I'm a social worker, so I always take notes. I have a question. If I went through treatment at Mercy, and I didn't really have an oncologist who spelled it out that way, so it was kind of piecemeal, I guess. Obviously, there have been follow-ups. Obviously, I've had CT scans. I don't know about a summary of treatment. And then referrals, like, he referred me to a palliative. I guess I'm just trying to understand if it's more concrete at Barnes WashU and they literally say to you, Joyce, our survivorship care plan is, I'm just trying to wrap my head around it because.
Oh, I don't know. I think that varies from person to person or from doctor to doctor. You have to ask questions. We
Okay.
have a lot of resources, but I don't know that we have that many more resources, for instance, in Mercy or SLU. I think we all have very similar resources. You probably just have to, I don't know, ask your doctor.
Yeah, and I ask a lot of questions. I've just never heard the phrase survivorship care plan, and I was diagnosed back on 10/5/20. So I'm just trying to wrap my head around that new phrase. It's a new phrase for me.
Yeah, that's sort of becoming, well, I think it's a new one, Joyce, for everybody in a way. It's the NCI or all the comprehensive cancer centers are required to have survivorship plans now. And I think that's part of the standard of care too. So I think all cancer centers will be instituting that, but as you can imagine, I mean, we're a work in progress. We don't, because a lot of places, or a lot of, survivorship is a new thing in many cancers because we're getting so successful in terms of their treatment.
Cool. Also, what does CER mean?
CER, I don't
I
know.
kept saying it and I kept seeing it in the slides and I'm like, I think everybody knows what CER is except for me.
So that is the cancer registry. It is a registry where people impacted by cancer can provide this information, and that's how they get a lot of this data.
Would you know what the E stands for, Danny? Cancer something registry. I just want to know in case I look it up.
I can get you the answer, Joyce. I don't know off the top of my head.
Okie dokie. Thank you.
Other questions?
I wanted to mention one thing. During the presentation, there were a lot of slides that referred to other materials, such as coping with the cost of care, or there was some, information about clinical trials, or worksheets to create question lists at doctor's appointments. We have those resources here at Cancer Support Community in our library. And so you are welcome to come to our place and pick up any of those materials that you would like.
Did you spell out? Does she want me to call her back?
Oh, I'm going to mute Dr. Mutt real quick. And also, we might be able to send them to you electronically as well. So just know that that is a resource here at Cancer Support Community. In addition, I wanted to let everybody know that we have a resource in the Cancer Support Helpline. And that information, and again, I'll actually just put their number in the chat here. Cancer Support Helpline, and their number is 888-793-9355. I just put that in the chat for everyone. They are staffed with cancer resource specialists and navigators that can also help you find different clinical trials, also to help, they can link you with financial navigators or other resource specialists to help meet your needs. So I wanted to also let you know about that.
Sorry about that. I got a call, so
Well, that's fine, Dr. Mutt. You're very busy. We appreciate what you can do for us.
So what other questions?
Yeah, this is Debbie. I have a question about the continual opportunities for additional research, because I know we hear in the press a lot of information about vaccines for pancreatic cancer. We hear a lot of the CART therapy. Are some of those additional therapies being looked at for the gynecological cancers as well?
Yeah, we have a CAR-T trial that's open for gynecologic cancers. It's not, CAR-T has been really disappointing in solid tumors, really well in the liquid tumors, lymphomas and leukemias and so on. But we're getting some success in some situations with the CAR-T therapy, but it's slow going. And as you know, it's expensive because you have to make you have to draw your white cells, grow them up, have them make antigens, or recognize then your cancer as foreign, and then you have to be injected. So it's expensive. It's $500,000 for a treatment right now, to develop those chimeric treatments, and it's it's slow going. I'll just say that for that type of therapy. Now, the immunotherapy we're getting much better at, pembrolizumab and so on. Yeah.
Thank you.
Did that answer your question?
It did. Thank you very much.
I don't know. I think WashU has CAR T cell therapy, but I'm not sure any place else has that technology.
Joyce, oh, sorry.
Yes,
And-
Dan.
I just thought of the name. It's Cancer Experience Registry.
Thank you.
And if you are interested, if anyone is interested in being a participant in the Cancer Experience Registry, you can go to the national headquarters website at cancersupportcommunity.org. And there is, a link on their page to participate in the Cancer Experience Registry. You can answer, a bunch of questions about your personal experience, whether you're a caregiver or whether you are living with a particular type of cancer. And again, that really informs the community about what the conditions and concerns of people impacted by cancer are. So it's great if you want to participate.
Okay, thank you.
Yeah. Any other questions? Okay. Okay, with that, I want to let you know that I did put the workshop form in the chat. If you could go ahead and fill that out. I wanted to also let you know this was recorded, and so we will have this in our resource library on our website. Any other final questions? I saw Mary, were you going to ask a question? Okay.
This is Debbie. I have one additional
Yeah.
question. Sorry about that. I
No
thought about it
worries.
last minute. It seems like we're moving towards being able to maintain and live with our diseases more than ever before. And I think I find that as a survivor being hopeful, but I wanted to get Dr. Much's take on that as well.
That is actually true. The overall mortality from cancer is not necessarily decreasing, but the survival time is increasing markedly. Just like, an example would be, not to be sad, but obviously the mortality of life is 100%, right? But we want to, go as long as we can with a high quality of life. And so I think that that's what the newer treatments are aimed at. Number one, targeting those features of the cancer that will slow growth or stop or make it regress, while at the same time not affecting normal cells. So much of chemotherapy is a poison, and it's a poison to your body and to the cancer. We just hope that it's more poisonous to the cancer than to your body, right? So that's why it makes you sick. But, some of the targeted therapies just affect the molecular feature of that cancer. So, those patients can be on that targeted therapy for many, many years. Avastin would be a good example. A PARP inhibitor would be a good example. Tamoxifen would be a good example for breast cancer survivors. So those are all options that exist. And we hope that those options will increase in number, such that, we'll be able to molecularly profile your tumor or your cancer and take, and specifically target those abnormalities that are different from your cancer when compared to normal cells. Did that answer your question?
It did. Thank you very much.
Your observation is true. Yes, it's clear, but we're also getting more and more long-term survivors. That is, those patients who have no evidence of disease. For longer and longer periods of time.
I'm sorry. I have a question. Do all tumors, cancers, have markers?
Not all have markers, no.
Okay. Thank you.
We're searching, or that we know of, we're certain, ovary does, gestational trophoblastic disease is the best. Some patients have colon cancer has a marker, but again, and some of those cancers don't express those markers either.
I have one more question. Sorry. What causes the tumor to grow bigger on the outside of your area than in the area that it's originated?
You mean like what causes it to metastasize?
Yeah, with mine, I had more of it outside of my vagina than I had inside my vagina.
Well, I mean, that happens. That's just a unique characteristic of subtumors, that they tend to grow better in the metastatic setting. But if we knew exactly why that happened, we would, that's an area of constant study. Yeah.
Laura, was part of the question also why did the actual tumor grow on the outside of the body versus the inside of the body?
Yeah, because there was more of it on outside of the vagina as opposed to it on the tube.
So not in the, well, I mean, that's sometimes just the pattern of growth. I mean, I don't think there is necessarily an explanation for that. I wish I could answer it better than that, but okay.
Any other questions? These are great questions.
I do have one more question, but I'll be seeing my doctor this Thursday. But
Sure.
Instead of having to continually go through these follow-ups, would it not just be easier to cut it all out?
I'm not sure I understand what sometimes it's technically not possible. In other words, like, if it's on the pelvic sidewall, you can't cut that away in the case of a vaginal cancer. Vaginal cancers are not, or it's so morbid to remove. If you have a vaginal cancer, for instance, often the bladder and the rectum would need to be removed, whereas radiation therapy would be better local therapy, preserving bladder and rectal function, and still treating the tumor. Nowadays, of course, in most situations, it would be that you might get a little bit of chemotherapy to make the radiation work better. But typically a vaginal cancer, surgery for a vaginal cancer is, can be very, would be very, very morbid. Cure rate would be less than radiation therapy, for instance.
Oh, okay. Thank you.
So surgery is not always the best.
Probably be depending on the location of the cancer and
Size.
yeah, okay. Great questions. We have a few more minutes left. If there are any final questions for Dr. Much. I want to remind people that we do have a gynecologic monthly networking group at Cancer Support Community. We meet live here at our facility. We also offer that same support group virtually. So it is a hybrid program. That program or, support group, it is facilitated by a licensed mental health specialist. And we hold that group on the third Monday of every month. That's for anybody with any type of gynecologic cancer. You're welcome to find support there. And we also have weekly support groups for people who are living with any type of cancer, who want to meet regularly and just talk, maybe less networking about their specific type of cancer, but just want to find support in talking to other people who are living with cancer. We also have a biweekly support group for people who are not in active treatment anymore, but they're maybe in the survivorship phase. And we also have a monthly networking group for people who are transitioning into that survivorship phase. They're finishing up treatment and they're looking for support in what's next. So I wanted to let you know about those different types of supports that we offer, as well as the ability to do some short-term individual counseling. We do have that option available now.
Oh, great. Well, so there's another resource for your
Yes.
counseling. Yeah.
Yes. There are 3 of us who are licensed clinical social workers, and depending on the load, we are available to take people. Generally, our short-term counseling is about 6 sessions, and it is cancer-related counseling. But it's also for people who are caregivers or also people who are bereaved by cancer. Sometimes we have the ability to extend those sessions a little bit depending on the circumstance. And I know that Dr. Much also touched on some other healthy lifestyle aspects in his presentation, healthy eating, as well as moving your body. And Cancer Support Community does offer a variety of cooking demonstrations, nutrition workshops, and movement classes, gentle movement, such as Qigong, yoga, and a couple different programs that do sort of a light strength training or aerobic activity called Fitness and Survivorship and Fitness Fundamentals. So
Okay.
just some more resources for you.
All right. Well, thank you. If it's okay with you, I'm gonna answer my patient's phone call. So
Yes, please do, Dr. Much. And this is a good time for us all to say goodbye. Thank you so much for your support of Cancer Support Community, Dr. Much. Thank you all for coming this evening. And let me know if you have any follow-up needs. We're more than happy to help you here.
Thank you very much.
Thank
All
you.
right. Thank you, everybody. Have a great evening.
You too.
Bye-bye.